Going to talk about the active management of normal labor. How do you manage normal labor? The aim is to achieve delivery of a normal healthy child with minimal physical and psychological maternal effects. Early anticipation, recognition, and management of any abnormalities during labor course. A is antenatal preparation. First is maternal education about the physiology of labor and symptoms of impending labor. Second is breathing exercise. Adapt the mother to breathing during labor to guard against respiratory alkalosis caused by hyperventilation. Normally, during labor, mothers tend to breathe fast if not educated prior to labor. This causes hyperventilation and subsequently respiratory alkalosis. So B is the first stage of labor. You begin with the history. You take complete obstetric history. You take history of present pregnancy. Ask of the duration of pregnancy. Medical disorders during this pregnancy. Complications during this pregnancy as antepartum hemorrhage. You take history of present labor. Ask about the labor pain, that's the onset, frequency, and duration. The passage of show, that's fluid or blood per vaginum. You ask of sensation of fetal movement. So second is examination. First is general examination. Check for height and build. Maternal vital signs such as pulse, temperature, and blood pressure. You do chest and heart examination. You check lower limbs for edema. Secondly, you do abdominal examination. You check for fundal level, fundal grip, umbilical grip, pelvic grips. You check for fetal heart sounds. You check for scar of previous operations such as cesarean sections, myomectomy, which is surgical removal of uterine fibroids. Third is pelvic examination. You begin with the acervix, which is the part of the uterus you feel through the vagina. You check for dilatation. The diameter of the external cervical opening is measured by the finger or fingers during vaginal examination and expressed in centimeters. One finger is 2 centimeters, two fingers is 4 centimeters, and the distance resulted from their separation is added to the 4 cm in more dilatation. You check for the effacement, that is the thinning of the cervix. You check for the position, posterior, central, and anterior. B, that's the membranes. You check for the membranes, ruptured or intact. If ruptured, exclude cord prolapse and meconium stained liquor. C is presenting part and its position. D is station of the presenting part. E is pelvic capacity. So you check for all these in the pelvic examination during normal labor. Fourth is investigations, if not done before or if indicated. Do blood grouping / rhesus typing. You check urine for albumin and sugar. You check for hemoglobin concentration and ultrasonography. So the active procedures are: first, evacuation of the rectum if need be to. This is to avoid uterine inertia. Uterine inertia means weak or absent uterine contractions during labor. 2 is to help the descent of the presenting part. Third is to avoid contamination by feces during delivery. Next is evacuation of the bladder. Ask the patient to micturate, that's to pass out urine every 2 to 3 hours if she cannot use a catheter. It prevents uterine inertia and helps descent of the presenting part. So third is the preparation of the vulva. The vulva is the external genitalia. You shave the vulva if indicated. Clean it with soap and warm water from above downwards. Swab it with antiseptic lotion and apply a sterile pad. Fourth is nutrition. When labor is established, no oral feeding is allowed, but sips of water or fluid can be allowed. So you give 15 ml magnesium trisilicate if indicated. You give intravenous drip of glucose 5% or saline glucose solution is given for energy and hydration. So fifth is posture. Patient is allowed to walk during the early first stage, particularly with intact membranes. So patient is allowed to walk, especially when the membranes are still intact. If rest is needed, the patient lies on her left lateral position to prevent inferior vena cava compression and hence placenta insufficiency and fetal distress. Sixth is analgesia, that's the need to get rid of pain. Petidine 100 milligrams intramuscular, pentazocine 30 to 60 milligrams intramuscular, trilene inhalation or epidural anesthesia are the most commonly used. Note that patients should not bear down during the first stage as this is useless. It exhausts the patients and predisposes to genital prolapse. So patients should not push. That's what they say the mother is putting in effort to push during the first stage of labor, that is during dilatation, as this is useless and it will exhaust the patient and predispose the patient to genital prolapse. So seventh is the pathogram, which is the graphic recording of the course of labor, including the following observations. The mother check pulse every 30 minutes and record. Blood pressure every 2 hours and record. Temperature every 4 hours and record. Check for uterine contractions, its frequency, strength, and its duration every 30 minutes by manual palpation or better by tachography if available. So tachography, also called tachometry, means the measurement and recording of uterine contractions. That is how strong, frequent, and long the uterus contracts during pregnancy or labor. You also check for cervical dilatation and record, fluid input and output and record, drug including oxytocins and record too. So let's move to the fetus. Fetal heart rate is measured every 15 minutes by penile stethoscope or better by Dopton. Descent of the presenting part, degree of molding, cardiotachography is available, is more valuable for continuous monitoring of both uterine contraction and fetal heart rate. particularly in high risk pregnancy. The advantages of the pathogram is that it allows right intervention in the proper time. For example, oxytocin usage, instrumental delivery, or cesarean section allows different staff shifts to manage the case successively. It serves as a document for labor events. So C